I'm Professor Adel Khattab, Professor of Pulmonary Medicine at Shams University, Cairo, Egypt, and I'm the head of the board for the Egyptian Fellowship for Chest Disease, and I'm a member in the Higher Supreme Committee for the epidemic respiratory viruses in Egypt. Today we are talking about the new disease, the COVID-19. How does person-to-person transmission occur? Mainly, it's droplet transmission. The virus is released in the respiratory secretion when an infected person coughs, sneezes, or talks. This droplet can infect others if they make direct contact with the mucous membrane. Infection can also occur by touching the infected surface and followed by eye, nose, or mouth. Droplets typically do not travel more than 6 feet, that's about 2 meters. Patients are thought to be the most contagious when they are symptomatic. Some spread might be possible before symptoms appear, but this is not thought to be a common occurrence. WHO now said there is no airborne infection. This is very important. No airborne infection. It's mainly droplet transmission. Now I'm going to talk about the clinical features. The incubation period. The exact incubation period is not known. 2 to 14 days after exposure, with the most cases occurring within 5 days after exposure. Spectrum of illness severity. Most infections are self-limiting. COVID-19 tends to cause more severe illness in the elderly population or patients with underlying medical problems. Mild illness is the common. It is in 81% of the patients. Severe illness. What severe illness means? Hypoxemia. More than 50%, more than half of the lung involvement on imaging within 24 to 48 hours. This severe illness in 14% of the patients. Critical illness in 5%. The criteria of critical illness: respiratory failure, shock, multi-organ dysfunction. Mortality between 2.3 to 5%. The age affected, mostly middle age, above 30 years, and the elderly. Symptomatic infection in children appear to be uncommon, and when it occurs, it is usually very mild. The symptoms, the clinical presentation: fever in 88%, fatigue in 38%, dry cough in 67%, myalgia in 15%, dyspnea in 19%. Pneumonia appears to be the most common and severe manifestation of the infection, pneumonia. In this group of patients, breathing difficulty developed after a median of 5 days of illness. Acute respiratory distress syndrome developed in 3.4% of the patients. Other less common symptoms, we have headache, sore throat, rhinorrhea, gastrointestinal symptoms. Diagnosis of the disease, the COVID-19. First, the case definition according to the WHO. We have the suspected case first. This is either a patient with acute respiratory tract infection, which means sudden onset of at least one of the following symptoms: cough, or fever, or shortness of breath, and with no other etiology that fully explained this clinical presentation. and with a history of travel or residence in a country or area reporting local or community transmission during the 14 days before the onset of symptoms. Or patient with acute respiratory illness having been in close contact with a confirmed probable COVID-19 case in the last 14 days before the onset of symptoms. Lastly, a patient with severe acute respiratory infection, that means fever and at least one of the following signs and symptoms of respiratory distress: cough, fever, shortness of breath. This requires hospital isolation. All this means SARI, severe acute respiratory illness, with no other etiology that fully explain this clinical presentation. But what about the confirmed case? Definition of the confirmed case: a person with laboratory confirmation of the virus causing COVID-19 infection, irrespective of clinical signs and symptoms, even if there is no signs and symptoms but laboratory confirmation of the virus. What is the definition of the close contact? Either a person living in the same household as the case. 2, a person having had direct physical contact with the case, shaking hands. 3, a person having unprotected direct contact with infectious secretion of COVID-19 case, being coughed or touching used paper tissue with a bare hand. Person having had face-to-face contact with COVID-19 case within 2 meters and 15 minutes. Number four, a person who was in closed environment, the classroom, meeting room, hospital waiting room. 5, a health worker or other person providing direct care of the COVID-19 case. 6, a contact in the aircraft sitting within 2 seats, if any direction, of the COVID-19 case. Travel companions or person providing care and the crew members serving the section of the aircraft. Any one of these is the close contact. What about the laboratory findings present in this disease, COVID-19? First, the white blood cells. White cell count can vary. It does not provide accurate information about COVID-19. Maybe leukopenia, maybe leukocytosis and lymphopenia, all these have been reported. Lymphopenia is the more common, seen in more than 80% of the patients. Mild thrombocytopenia is commonly seen. However, thrombocytopenia is considered as a poor prognostic sign. Inflammatory markers, serum procalcitonin is often normal at the time of admission. However, it increases in patients who require ICU, the critical patient. C-reactive protein, COVID-19 increases C-reactive protein. Patients who meet the criteria for suspect cases should undergo testing of SARS-CoV-2. Now it's called either COVID-19 or SARS-CoV-2, because we have SARS-CoV-1 before in 2003, and also other respiratory pathogens. Recommendation for sample collection. First, collection of the sample to test for SARS-CoV-2 from the upper respiratory tract, that means nasopharyngeal and oropharyngeal swabs, either from the nose or from the oropharynx. This is the preferred method for diagnosis. Induction of the sputum collection, this is not recommended. Bronchoscopy being an aerosol procedure, has got the potential to transmit infection to others. In view of this, preferably avoid performing it and limit its use, clearing secretion, mucus plug in intubated patients. All respiratory specimens collection procedure should be done in negative pressure rooms. The current recommended diagnostic modality for COVID-19, SARS-CoV-2 RNA, is detected by polymerase chain reaction, RT-PCR, real-time polymerase chain reaction. If we have a single positive test, this should be confirmed by second RT-PCR assay targeting a different SARS-CoV-2 gene. If initial testing is negative, but there is a high suspicion of this case, the WHO recommends resampling and testing from the multiple respiratory tract sites. This is for the real-time PCR. We have also another test, the COVID-19 rapid test. This is for screening. This is a rapid test qualitatively detects IgG and IgM antibodies to SARS-CoV-2 in human whole blood, serum, and plasma samples. What about radiology in diagnosis of COVID-19? We have first the chest X-ray. The findings on chest X-ray are not specific, and in the initial phase of the disease, the studies said that chest X-ray could be normal. But if there is abnormality, the most common features include lobar, multilobar, and bilateral lung consolidation. The most important radiology modality is compute tomography CT chest. And in many studies, the sensitivity of the CT chest is higher than the sensitivity of the PCR. What we can find in the CT chest, there is 4 stages. Early stage, between 0 and 4 days after onset of symptoms, there is a ground glass opacity, and this is frequent, mainly subpleural distribution involving predominantly the lower lobes. Second is the progressive stage. From 5 to 8 days onset of symptoms, we have crazy paving and consolidation of the airspace. 3 is the peak stage. From 9 to 13 days after onset of symptoms, the consolidation becomes denser, more dense, and it was present in almost all of the cases. The final stage, this is the absorption stage, more than 2 weeks, more than 14 days after the onset of symptoms. No crazy paving pattern was observed. The ground glass opacity could remain. The management of COVID-19, this depends on the severity of the illness. First, we have the mild illness. This means without any risk factors or comorbidity. What is the plan in the mild illness? Outpatient care, strict home quarantine mentioned by the government or the health authorities, supportive measures, but most importantly, assess patients' clinical condition via telephone conversation or using telemedicine facility if available. In the moderate illness characterized by dyspnea, hypoxemia, infiltrate or consolidation on the chest X-ray or CT scan, should be admitted in a hospital, isolation room, supportive care, start empirical antibiotics as per local community-acquired pneumonia treatment guidelines. Oseltamivir, either 75 or double the dose, 150 milligram twice a day. Consider starting hydroxychloroquine or, if available, lopinavir or ritonavir if evident risk factor for progression of disease are present. Lastly, in critical illness characterized by these patients in the mechanical ventilation, and there is multi-lobar bilateral consolidation, careful using these drugs in patients with multi-organ damage. Remdesivir for compassionate use only. Tocilizumab can be considered. Check if interleukin 6 level prior to starting tocilizumab, especially in patients with evidence of cytokine release syndrome. Continue IV antibiotic and supportive care. Rule out ventilator-associated pneumonia or castor-related infection and other secondary bacterial or viral or fungal infection. Always keep in mind that to rule out differentials of non-resolving pneumonia, in ventilated patients, follow RDS net protocol strategy. Consider ECMO if need arises. Lastly, refractory or progressive case in ICU, interferon beta B1 can be considered. However, it should be combination with an antiviral, lopinavir, ritonavir, and hydroxychloroquine. What about the PPE in this COVID-19? PPE means the personal protective equipments, mainly the recommendation for the usage of the circle triple layer face mask or the respirators. Asymptomatic individuals wearing mask of any type is not recommended. Wearing masks when they are not indicated results in unnecessary cost and procurement burden, especially during the time of an epidemic or pandemic. People with respiratory symptoms or who are taking care of COVID-19 patients at home should receive triple layer surgical mask. Respirator like N95 or FFP2 or equivalent should be reserved for aerosol generating procedure like tracheal intubation, non-invasive ventilation, tracheostomy, bronchoscopy, and cardiopulmonary resuscitation. Healthcare workers who are involved in direct care of COVID-19 patients should use 3-layer surgical mask or respirator only if available in sufficient quantities. Medical and nursing staff involved in intensive care unit should use respirator or equivalent. During the present pandemic situation, respirator like N95 can be used for an extended time, especially while caring for multiple patients who have the same diagnosis without removing it. Always prioritize the use of N95 respirator for those personnel at the highest risk of contracting infection. Most often, an N95 mask can be used for up to 8 hours on a continuous or intermittent basis, and ideally it needs to be removed after that. Avoid touching the inside of the respirator if inadvertent contact is made with the inside of the respirator. Perform hand hygiene. Lastly, using mask should be considered as a potentially infected material, and it should be disposed separately in an infection waste disposable bag.